Thank you. Let me quickly introduce the team. I'm here with Taral, Patel, and Calvin, who have been taking care of this patient and set up this case and did all the heavy lifting. And then I'll introduce the other team later because I think Ashish is ready in the other room. We had a lot of challenges this morning setting up the case, so I just want to quickly have Calvin present this case, and then we'll go up to Ashish while we are working here.
So we have a 73-year-old female with a past history of end-stage renal disease and GI bleeding due to a dolophoid lesion that's been controlled despite aspirin and Plavix and on atrial fibrillation with tobacco abuse. She has a history in terms of valvular disease of moderate severe stenosis, moderate AI, moderate MR, and she presented with symptoms of dyspnea and chest discomfort with walking 25 feet. As we'll see on the angio, that she basically has an osteal lesion, mid-LAD lesion with aneurysm and osteal circumflex. We did have a multidisciplinary meeting with the surgeons where she was deemed not a candidate for CABG AVR due to frailty, and maximally tolerant medical therapy is metoprolol succinate 25. These are angios from before, and we actually have them today. She has a CT to the right, and on the right, you can appreciate she does have a osteal LED, an osteal circumflex lesion. Next slide. We did do physiology as well as intracoronary imaging already. I had an IFR of the osteal LED of 0.78 and the circumflex of 0.76. The areas are about 6 millimeters squared for both. Next slide. And this is her echo. Her ejection fraction is normal. She does have moderate AI, the mean grade of 36 millimeter mercury, and moderate MR. And Sharma.
Yeah, so I think we had a lot of discussion whether, if she's a TAVR candidate and whether to do the PCI upfront or after the valve replacement. So that's one topic. And the other thing is how to fix the left main, whether to use hemodynamic support or not. So we tried to do a right heart cath this morning. Can you show the images? Her iliacs were like extremely calcified, tortuous, and stenotic, and so we had a fair amount of struggle this morning. You can see there's a kind of a tram track calcium on both the sides, and go to the next one. So we just had to hit the calcium on under ultrasound and fluoro. Go to the next slide. Her SFA is occluded. Next slide. And even getting the swan from the left femoral vein was like very tortuous iliac vein, and then we had trouble even getting the swan. Go to the next slide. So we used a JR4 and got the wire up. Next one. Then we had an issue with, so as soon as she was on the table, she decompensated her. You can see her, she's in AFib with RVR. Her blood pressure is in 120s. She's on norepinephrine right now. Her heart rate is in 120s, blood pressure is 110s. We did a right heart cath. Her PA pressures were in like 50s systolic. Her wedge was about 14 to 18, I think. And her cardiac output is okay because she has fistula and she's a high flow state from the end stage renal disease. So because she decompensated, we decided to put an Impella for this PCI case, and then getting the Impella sheath was also very difficult. And you can see here a lot of tortuosity and very heavily calcified. We couldn't straighten the iliacs. Go to the next slide. Eventually we were able to get the sheath up, but what happened was the Impella sheath actually kinked and then split at the hub, so we had to switch it out for a 14 French Cook sheath, and you can see a lot of tortuosity here. Next slide. Next one. So we eventually were able to get the Impella up. You can see the calcification of the distal aorta as well there. Next slide. Next one. This is the Impella going through the stenotic valve. Her valve is like moderate to severe. Her valve area calculated was 0.7, but it's actually about 0.9 to 1 millimeter square. So we were able, or centimeter square. So we were able to get the Impella easily. So these are the setup shots. So that's where we are. She's stable. She's on a little bit of norepinephrine. Heart rate is okay. Her PA pressure, I think we need to hook up the swan for live monitoring. And we're going to wire an IVUS and image, and then we'll go from there. So that's where we are. And I think for the interest of time, if or you guys want to go to a sheesh on the other side, and we can come back and go back and forth.
So a lot to talk about, incredibly complex. You've got severe AS, you've got significant multivessel left main coronary disease, challenging peripheral vasculature, and really then multiple questions as to what you do first and how you accomplish it. So I'm going to take a couple of minutes while we transition and let you do what you're going to do. So Sudeshna, in your lab, how do you make these decisions of, do we tackle the TAVR first or the coronaries, specifically in this type of case or in any type of case? What's your algorithm?
Asking me?
I guess grab an OCT as well.
So we
We don't have the
we talk about all of these cases at our multidisciplinary conference, and we really try to differentiate. If it's sometimes hard when you have these patients with AS because you don't know if they're having anginal symptoms or AS patients are having just the typical heart failure or chest pain. But we really look at if the lesion is critical or proximal, and that's how we determine if we're going to treat it beforehand or after. And that's really served us well. You know, we don't want to rapid pace or put someone under a lot of anesthesia if they have these critical lesions that they could decompensate like we're seeing here. But we also have seen that we can get away a lot of the time with just doing a TAVR, and these patients tend to do well if the lesion isn't critical or proximal. They tend to not have a lot of angina after, and if they do, it's easy enough to fix it later.
Alok, we are back with you at HonorHealth. How are you doing?
Oh, guys, so we can go back. I don't know. I don't remember where we left, but
Are you guys at a good place to stop? That's a good question. I mean,
If not,
you've gotta
you keep working.
I think we're going to just deploy this tent, and then we'll talk.
We're going to go back to that. We're going to go back to that.
All right, go up there.
Yeah, good there.
Hold on, let me pull the wires back. All right, go up there.
Okay. Up. Down. 15.
She loves that. Yeah.
Yes. That's a good point, because when our first initial inflations, her blood pressure was in like 40s systolic.
Yeah.
And when we did the kissing inflation, it was even, it took a while to recover. And you can see the PA pressures are in the 70s now. We started with 50s. And this is with the Impella, and she has these diffuse ST depressions as well.
Alok, I'm just looking at the pictures here. You might need to push your Impella in a bit.
Yeah.
Oh yes, good point. I'm glad you guys are there.
It's the current is pretty good,
Happy
and
to
we're getting
help.
good flow. It's a little bit positional, this guy.
But you're correct.
We're in a
that
pretty,
it is,
yeah.
There it is.
All right, so let's go back to where we stopped, because I think we have some time to go over this case now.
Awesome.
So we had some hiccups when we started the case. She was unstable. We couldn't get the Impella sheath up because it kinked and then was very tortuous. So eventually we got a Cook sheath, and with a lot of dilatation, we got the sheath up. So we had to get access on the other side. So it's the 7th French left femoral arterial access and the 7th French guide. We have an ongoing pressure swan monitoring. Her PA pressures when we started were 50s, and they've gradually gone up to 70s now. How much norepinephrine is she on? She's on 3 mics of norepinephrine right now. And her heart rate has been in 120s, which is stable. Her blood pressure has gone up after the stenting to like 130s and 140s. But let me go back to the angiogram. The first picture we took, you saw there was a 011 Medina lesion, so osteal circ and osteal aridemia, and maybe some distal left main disease. She has a CTO of the RCA, which is a kind of a co-dominant vessel with some collaterals from the left system. The OM1 has some disease as well. And, obviously, we have to do imaging. I think it's a must in left main cases. We can't emphasize that enough. So that's, go to the next slide, next Cine. So we wired both of them. These are just standard run-through wires, and we IVUS both the limbs. Ankur, you want to go with the IVUS, please?
Yeah, of course. So, can you hear me?
We hear you.
We got you.
Okay, excellent. Yeah, so we are on the Avigo Plus system. This is the upgrade of the IVUS with AI built in to help us with automatic lesion assessment. So if I turn this on here, you can see that it will draw luminal areas as well as where the software thinks is the media with the blue lines, and will give us both the luminal and the medial diameter. So these upper numbers as the minimal luminal areas, the medial area, and the luminal diameter, medial diameters, and the overall plaque burden. So I'm going to take those off for our eyes. So this is the IVUS of the LAD, Prox LAD into the left main. You can see the LAD is massive. It's at least 5 millimeters in diameter. You can see the start of the eccentric calcification in the LAD from 6 to 12. And as I scroll from the Prox LED towards the left main, you can start seeing the calcium is becoming near 360 degrees with very tight lesion here in the Prox LED. And that's the close to the ostium of the LED. You almost have no lumen left with a luminal area of 1.7. Near 360 calcification starts to open up. That's a circ wire coming in. Distal left main, eccentric calcification from 1 to 7.
12.
And then the left main is reasonably big with luminal diameters of 5.5, probably more like 6.0. This is the IVUS run from the proximal circ to the left main. So circ is massive. There's an area of aneurysm here in the proximal circ, but as you scroll back, you start to see the circ forming. Here you can see the circ ostium is fibrocalcific. So from 2 to 5 o'clock, that's a fibrous lesion. You can see behind the white area, all that is fibrous tissue, which we commonly see in the circ osteums, just like RCA osteums. They can be very fibrotic. But then there are areas of calcification, but they are small focal areas of calcification at 12 o'clock and 6 o'clock. And as I scroll back, the MLA gets really tight. Again, staying fibrocalcific. That's the minimal luminal area of 1.1 on the circ ostium. And then the left LED wire is coming in. Near 360 degree calcification here in the distal left main. And this is the left main. Again, medial diameters are probably close to 6 to 6.5 on the left main. But we can achieve luminal apposition with a 5.5 to 6.0 stent, the max we can achieve.
Yeah, so, and we tried to do OCT, and I think it's such a high flow state because of our dialysis, fistulas, and really big lumen. So OCT wasn't able to clear the blood, but we tried to do that so we can get the depth of the calcium a little bit better. But go to the next sentence. So I think I'm curious what the panel would do. Would anybody, based on the IVUS imaging, just what would be the strategy? We do modification, calcium modification, or go with NC balloon, or?
All right, it's a great question. So this is a great demonstration. You've got very tight biostia with a massive left main, calcium on both ostia. Okay, so Farouk, how do you want to tackle this? Is this going to be NCs, specialty balloons, or IVL, or are you going to take one thing at a time and see how it responds in a lady like this?
Sure. Again, the most important thing here is being able to have imaged up front, and it was really done well. It's high resolution, and you can see everything you need to see. It's a really large vessel, and so the Prox LED is also involved there, and it's great that the IVUS went past that. Because the lesions are relatively focal, I think you really have all the options on the table. I think I would look at NC versus a scoring balloon as my two choices. I think, scoring balloon is probably usable in the Prox LED. The osteo of the LED and the osteal circumflex with a single balloon might be an efficient way to do that. And then look at that expansion. But because it's focal and not really 360 over a long period, I don't think I saw anything longer than 5 millimeters here that was 360 or 270, I think I would start with scoring probably.
I think another.
All right, so Alok, so tell us what you did.
Yeah, so I think go to the next. So totally agree with Dr. Jaffer here. I think we did, this is a Wolverine 4 millimeter balloon. We went up to 16 atmosphere, even though, the rated burst is, the nominal is 12.
So this is a
Go to the next
4.0,
one.
5.0, what size cutting balloon is this?
4.0.
4.0, okay.
And you can see there's recoil. Go to the next one. And then we did some few inflations. We left it up, but then she was very unstable, so we had to do quick inflations. Go to the next one. And see there's a little bit of waste in there. Next. Next. And a little bit better, but still you can see a big waste there with recoil. And then we did the same thing with LAT, same balloon, a 4 millimeter cutting balloon. Go to the next one. And a little bit better expansion, but again, next. And eventually, I think we, with few high pressure inflations, it's a semi-compliant balloon, so it's not an NC. Go to the next one. And then we went back with an NC balloon. This is a 4 millimeter NC to like 22 atmospheres. And you can see now you don't see the waste in the balloon. Again, a little bit undersized. I think we could have used a 5.0. And then we IVUS both the limbs again. Go to the next one. And that's where we are. Ankur, you're going to just quickly in a minute go over the IVUS, please.
Yeah, so on the LAD, I agree with, I think Farooq mentioned, so there are areas of 360 where it's less than 5 millimeters. We can't tell the depth of calcium. There's fibrotic lesions. So I think that's why we chose the Wolverine. You can see there's some modification of the LAD close to its ostium on the 3 to 5 o'clock here. Can we show the ICT image of the OCT image of the CIRC? Sure. Can they see the OCT? Yeah, they can. Okay, yeah. So we attempted the OCT of the CIRC. It's a perfect storm because she has high flow state and massive vessels to get a picture, but we did manage to get a frame of the ostium of the CIRC. This is the CIRC ostium. You can see the fractures of the calcium at the 12 o'clock and 1 o'clock. So there was a pretty good modification of the CIRC ostium. Back to you, Alok.
Yeah, so I think that's where I think then we decided to see if we can go ahead with the stenting unless somebody thinks otherwise. And again, up for discussion whether what stenting strategy would somebody use.
Well, let's talk briefly about that. So, Nadia, what two-stent strategy, one-stent strategy, provisional? What do you want to do here for this particular patient?
Yeah, I think this is a tough one because, I think, that they're both pretty short lesions. And so, I think in some cases I might lean towards a provisional strategy, but then, we just had to use a cutting balloon. And I guess I would be a little bit worried. This seems like a case where, gosh, maybe even, I don't know if we have a drug-coated balloon that would go that high in terms of the diameter, but that might be a good option would be to, stent left main into the LAD and then drug-coated balloon into the side branch.
Yeah, Rob, anything different here in your lab?
I'm going to shoot straight with you. I have been these short focal circs like that where you're just worried about provisional just based on some of the DK crush data. I got to be honest, I think this might be where I use a DCB in the circ and stent the LAD back.
Okay.
Because where do left main two-stent strategies fail? They fail at the ostial circ. And a lot of that time is from nodular calcium and such, but I don't know. I'd be definitely thinking about it right now.
Yeah, the ostial of the side branch here, the circ, which is codominant, is your weakest point, and you want to make sure that that's not going to be problematic. So, Alok, what did you decide to do? Take us through it.
Yeah, I think those are great points. I struggled with that because, the more you do, you see these patients come back, even with like DK crush, which has probably the best data. It's the ostial circ that always is least in oath. So, just because we had a difficult time, it's such a recoil lesion and kept recoiling back, we decided to stent it just to keep it open. And we decided to use a DK crush strategy. So this is, go to the next slide where we left. So we stented the left circumflex ostium with a 4 millimeter drug-eluting stent. to high pressure, and then did a post NC balloon dilatation. Make sure it's expanded. No, go back to. Keep going back. Back.
I'll put out because I do everything wrong. So because of the circ issue, if I was going to do a two-stent strategy, and for the most part, I tend to make the circ the mother.
Yeah.
Because you end up, it's the side branch that gets the restenosis, and the circ ostium is the thing that actually has the most fibrotic recoil. Right. And also recrossing the LAD is super easy because the angle's super easy. So I will just put out there as a different approach is try to make the more highly angulated vessel the mother, and the straighter one the daughter, which for me means most of the time I'm going to make the circ the mother. The reason everybody's been trained to make the LAD the mother is because you think it matters more. It has nothing to do with what's actually the issue, which is the physics of putting in the two stents. So just to put out a thought-provoking way is consider maybe making your circ the mother more frequently than you do.
Yeah, and in these types of cases,
those
again,
are great
against
points,
data,
Bill. I think
I like the cool-out technique as well. Here, you could use that if you wanted to do two-stent and make the circ your angulated first stent and really make sure you've got expansion on that origin.
And just to add on to that, we can pontificate about stent strategy, but we're also talking about a patient who we've heard numerous times about them being unstable throughout the case. So I think there's the reality that you have to think about too. I need to have a backup. What can I do the fastest? What's going to give me the least trouble so that I can reduce the amount of time that I'm intervening? Even going back to the shockwave discussion, she was having hemodynamic instability with balloon inflations in the left main, and while shockwave's an excellent therapy, she might not really tolerate that. And if you use side branch on the circumflex and then you struggle to recross it and you're spending a lot of time doing that, then you can also encounter some more hemodynamic instability. So I'm curious on the panel, we all have our preferred stent strategies. We have data to support one over the other, but in a clinical scenario like this where you're potentially trying to reduce the amount of time that you're in the procedure, would that change your strategy as well?
Alok, show us what you did with your DK crush.
I think those are excellent points, and it's to counter that. I think we're also struggling with if we stand the left main to LAD first, and then there's a big dissection, and so I think, but Bill's point is excellent. I think it's so what we did was we ended up doing DK crush. We put a stent in. I'll go back. Sorry. And then we crushed the, one more back, crushed the stent with the 5 millimeter balloon, go back.
The other thing I think it's important for everybody here, nobody knows what the right answer is. That's a retrospective analysis. So obviously there's lots of different ways to do this, and Alok's done a great job with it. None of us should sit up here and say we know the right answer. The right answer will be in a year whether this patient gets restenosis or not.
I mean, the other thing to know is there's another major trial. We focus on DK crush, but the EBC main was, very successful as a provisional upfront stent strategy. And even as Rob mentioned, if you went and did your DCB or you did your NC, if you just stented across left main LAD, and then you went back to deal with the circ, and you didn't like your balloon result, you still have a pretty straightforward tap option here. It's an angle that's kind of separated nicely now with the wires. And that would be a very fast approach, speaking to what Rebecca
You also
was.
have a late cool-out option here as well because the circ's so big, but you got a lot of stuff.
Yeah. So I think in the interest of time, so what we did was we stented it, and then we did wired it through the proximal stent struts, go back, and then did a 3 millimeter balloon to open the stent struts, and then did these are two 4 millimeter NC balloons at 12 atmosphere, did sequential kissing. And then we ended up stenting the left main to LAD with a 5 millimeter Megatrons, 4 millimeter Megatron stent. And then here we're going to do a proximal optimization with a 5 millimeter balloon here. Go up there. And then we'll recross it and then kiss it and then re-IVOS this. So,
Up
That's terrific.
15.
Have people moved
and
on?
I think Ashish is ready on the other side. I'm just going to do one more inflation, take a picture, and maybe once you come back, we'll have the IVOS results. Go up there.
Great. And you're planning to put a 5.0 in Alok in the left main? LAD?
This is 5.0. This is 5.0,
5.0,
yes.
okay, yeah.
Down 15.
And are people doing their bifurcations pot, kiss, pos? Pot, kiss? Pot, kiss, pot? Based on the data from a couple of years ago,
Yeah.
So pot, kiss, pot again.
Let's take a picture.
Yeah. Recoil
You
there.
know,
Yeah, so I think there's still recoil of that osteocirc. So we'll IVOS it and hit it one more time when we recross it and see if it prevents recoiling. So
Okay, well, we're going to let you work and come back to you when you're done, and you could show us what this looks like. It's making great progress. We're going to go back to Chandler and Ashish Prasad.
Hi, Manish. So we're set up for our final IVIS run here. So I was able to, so what I did was I switched out the guide extension to a 6 French coast, which is a little bit more softer and malleable, and was able to then bring it down past that bend in the mid-right, put in a 3.0 distally, 3.5 proximally. We post-dilated them all, and right now I have my IVIS catheter sitting just past the distal segment, and we're going to pull back, and I wanted to show you guys the live pullback. So you can see that it's a 3.0 distal vessel, which is the size of our distal stent. I don't see an edge dissection. And we're getting into our landing zone here, which looks reasonable. Pulling back. Here it is. And in MLA, we're looking at a little bit compacting the pack. 3.0, I think, is an appropriate size here. Coming back. Still well expanded, well opposed. We'll measure a cross-sectional area there. Make sure it's more than 4.5 or 5 all the way back. A little bit maybe needs a little bigger size balloon here. This is a 3.5 stent, probably needs to be expanded again a little bit. We'll measure a CSA here, clearly underexpanded in the proximal segment, so we'll hit that.
And you see, and you see that elliptical or D shape, that has no meaning. It still comes down to it's about the cross-sectional area. So a D-shaped stent is an okay stent as long as the MSA is good. So
John, can you just go to the tightest spot and do a couple of MSA runs? So that would be one right there, right there. Yeah, give us an MSA there.
Yeah.
So it's really nice to have super users in the lab with the system that you're using. So not everybody has a Vigo and AI to give you the measurements, but having somebody in the lab helps. So it's 6, even though it's crazily elliptical. That's pretty nice. This is in the mid-right. I would accept that. Anything more than 5.5 is my cutoff based on ultimate. Keep coming back if you need to. There's, I think, proximally there. That looks a little bit less than the previous area. So measure here. Still is probably going to be more like a 5, I think, 5.5 maybe.
Ashish, just to fill us in,
6.
before you stented, did you do another non-compliant balloon inflation, or did you do anything different, or did you just move ahead with stenting?
No, because I had to get the inch liner, Michael, to get past the, I had to inchworm the guide liner, so I basically took the advantage of having a 3.0 NC and basically redid the whole thing all the way down to the crux while I got the guide extension down.
Okay.
So I didn't have to struggle with the 48 millimeter stents. So there are 2 48 millimeter stents. So as Manish was saying, it's like almost a 90 millimeter, right? That's stented. You can make a case of, it's a little bit.
That spot's a little problematic.
Yeah, that's a problematic. That's real proximally, honestly. So I'm going to hit that with a 4.0 NC and then leave the rest alone and then take a final shot and be done. Yeah, that's the spot he's going to measure for us. And you can tell that it's clearly unexpanded all the way from 12 o'clock to 6 o'clock. Yeah, that's going to be like 3 or less, like 4.4. So I'm going to hit that hard with a 4.0 NC proximally, flare it up, and then I think we should be good to go.
Terrific.
Agreed? Any questions, input, output, any thoughts from the panel?
This you just have to hit a couple of areas, and this is going to come out nice. You have an angiogram, so we can all ooh and ah.
Yeah, no, I don't want to. Sure, I can show you something here. Let's take one real time.
You want a long?
Yeah.
Terrific. Absolutely terrific. Great. You got just touch up the proximal, and it's going to have good expansion. And I think, look, You've got big branches, a massive RPL, and the PDA system. The patient's obviously doing very well. You've got completeness of revascularization on the left main, LED circ, and now the right. And I think this has been a terrific demonstration, Ashish. Thanks so much.
Yeah, you're welcome. I don't think you guys can handle the load, and I think I'm just going to post-dilate and then get rid of the external gear and be done. So once again, thank you for giving me the opportunity to work from Chandler and interact with masters on the podium. So appreciate it, and we'll catch up with you guys this afternoon when I come over there.
Fantastic.
Thanks, Bill.
Great.
Appreciate the moderation. Bill and Manish, thank you for your time.
All right. Thank you. Well, let's go back to Honor and Alok and company and see how they're doing. Alok, we are back with you.
All right. Thank you. So what we have done so far is after we went off camera, we dilated the circ with the 5-NC balloon. We kept the balloon, tried to leave it up for a little bit, but then, her pressure was in, again, 50s and 60s systolic. And go back here. Let's show the 5-0. One more back. And you can see this is a 3-0 balloon to open the stent struts. Go next. We didn't save the floor up. Okay, so this is going up. I think this is a 5-NC balloon to like 14, 16 atmosphere. Next one. Oh, yeah, we didn't save that, but I think that's where we are. We're going to. So after we left, we recrossed it through the stent struts. This is a 5-0 balloon, and we're going to do a kissing inflation with a 5 millimeter balloon, and then this is a 4 millimeter NC balloon in the.
Yeah, I mean, my experience has been exactly this with osseous circs, as we've been talking, that being the weakest link. Even with good expansion, you almost always get recoil. You're not exactly happy after you've treated it with some kind of two-stent technique of your choice. And I must say, I'm going more and more to prepping with IVL and getting much more expansion up front with less recoil. Again, I don't know if that's going to make a difference or not. Time will tell. And again, Rob's thoughts on treating this with potentially a DCB, Rob. The question is are we going to be able to attenuate the recoil in these types of cases?
And go up to 12. Oh, you have the circuit.
That's what I was saying. That's what I was saying.
Let's do who has the circ here.
I have the circ. How much?
Wait till it comes down.
It seems like you still have a little recoil based on the waist on the balloon.
Go up on whoever has the circ balloon, go up on the circ. Okay. Go up to 12. Okay. Leave it up there for a second here. Okay, go down to 12. Go down to 12.
The typical kissing balloon is a two-step kiss, which is what Alok and team are doing. High pressure one down, high pressure second down.
And you can see her pressure just drops to negative.
And then both simultaneously like this.
And I think that's why I'm glad we did the hemodynamic support. You can see this is what we have been struggling with. So it just gives us more time and to do this in a better way rather than rushing it.
This is an 8 French guide, Alok?
7 French.
7, okay.
Let's take a picture. Yeah. Okay.
Not a flow, but it looks like it's better.
And we'll just IVUS this to see what's happening, and maybe we'll have to do.
The pot may be good, and then IVUS you might be fine here.
Yeah, it's a really big vessel, so I think that's. But I think we want to make sure that we do a good job here, and I think the imaging might help us a little bit. And we can still do IVL if needed, but I doubt it might help us too much here.
So we're going to stick with you. We've got another about 12 minutes of transmission time.
That's IVUS.
And before we get to our break and the exhibits. been a very
While we are
instructive
working,
case.
I would love to hear, we have all these experts in the panel, what they do, aortic stenosis and significant proximal three-vessel disease. At my institution, I think this is a case where I might consider doing TAVR first, but again, I think we have a couple of trials coming up, complete TAVR, and that might help us making decisions. But I think this is also one of those things where we don't know. The data is not out there. I think there was one trial, I think, which was non-inferior. PCI did not meet the non-inferiority endpoint. So I'm just curious, just open up for discussion.
Yeah, no. So we were talking a bit about this, I think, as we went off camera the first time. And again, at least in many institutions, the switch has been towards TAVR first in these critical AS cases, and then coronaries thereafter. We've certainly seen that when I was at Columbia and in our entire NYP system. Bill mentioned that is definitely what they're doing in Seattle with Jimmy McCabe. Farouk, what are you guys doing at MGH?
It's a great discussion. Whenever it's possible to do TAVR first, I always prefer that for multiple reasons. That just really de-stresses the rest of the coronary procedures. This is a tough one. This really, it's a prognostic issue with left main equivalent disease, and it's hard to know what to do in this situation. Will you get away with a straight TAVR alone? It's why we need the trials and so forth. But if I did not have left main disease in a situation like this, I would always prefer TAVR up front.
I think most institutions are doing TAVR first at this point. The one caveat, though, is when you have a severely depressed EF where you know that the depression of the ejection fraction is due to both aortic stenosis and coronary disease, because you're not going to get full recovery of your EF with just doing the valve, right? You're certainly going to have improvement, but if you potentially need mechanical circulatory support to do the coronaries after the TAVR, that's where you've really got to think, because as everybody knows, because they got fun emails like last year, I think it was, Impellas and TAVR valves don't seem to do very well, particularly certain valves. And so that's the one thing in this case that I think at least we would pause in our heart team and just have to discuss. But, curious what other people think about that.
I think that's a really good point. I mean, for us, it's still, I think we have still trended towards doing the proximal coronaries because it is a multidisciplinary discussion and trying to convince our anesthesiologist when someone has, 95% LAD to put them under is sometimes not worth the pain, and so we just tend to go ahead with the TAVR. But in terms of considering this patient or other patients when you know you're going to need support later, I think we don't, always want to instrument a new valve if we don't have to, and so doing this up front. It also, again, is it critical aortic stenosis? Is it critical left main? There's a lot of gray area between that, so every patient isn't the same. So if you have a patient with moderate to severe AS, you can probably get away with, treating the coronaries, making them feel better, and making that TAVR procedure a little bit more comfortable.
So the other alternative I would show you or tell you about is, when I was in New Jersey, how we handled these cases was we actually did a combined procedure. It started with a 5-5 Impella, and then it did the coronaries, which were left main bifurcation, and then it finished with the TAVR. So it kind of deals with both issues. I think one of the issues you're seeing here in this case is that you're struggling with maximal support from the CP catheter. You do kissing balloon inflations within the left main with the CTO of the right coronary artery, and you're running into significant hemodynamic issues. And so that's a combined effort with the surgeons for the percutaneous intervention as well as the TAVR, but just to throw out a different option.
I think the other take-home point I'd like to make is there isn't a right answer here. The wrong answer is to not do the case. And you have to accept that if you take this case on, she can die. And that's one of the reasons we avoid stuff, is we don't like that to happen because emotionally it's very difficult. So the thing for all of you to work on is how do I build an environment that's going to accept that we tried, that we unfortunately, we love acts of omission because they emotionally don't hurt, whereas acts of commission do hurt a lot. And we have to work on our cultures to state that we're going to build environments, because acts of omission, avoidance, harms way more people than acts of commission.
All that being said, I think they're going to end up with a great result here. You know, the area within the osteal LED and the circumflex, as far as I can tell from the imaging, is pretty damn big.
Hit the middle part of it.
So I'm liking this lady's chances.
14 down.
Yeah, that's absolutely correct. We'll finish this and then I'll re-kiss this at the end, but Gupta, and then we'll go over the IVUS here, Dr. Taral.
I guess just
so this is a 5.0 NC balloon.
14 down.
Yeah, then just take a picture and then go over the IVUS results. And
You've just finished a pot, and now you're going to go back and do kissing?
I just have to re-IVUS the osteal circ because it might change the dynamics, but we can go over the IVUS.
Yeah, let's do
The reason
that.
we did
That'd
the
be great.
5.0 was to look at the osteal LED was a little bit underexpanded. That's why we did and not because of the repot, but Ankur, can you go over the IVUS?
Yeah, so this is post-stent LED IVUS. I'm starting from the distal edge of the stent that's coming in, some malapposition of the distal edge that just needs to be hit again with NC.
And we just did that. That was another reason we did that 5.0.
Right, but rest of the stent is well opposed. We're getting close to the ostium of the LED. This is the worst area of the stent expansion. There's about 45% stent expansion here, but when you look at the MLA in this territory, it comes out somewhere around 5.4 millimeter square minimal stent area in the ostium of the LED.
And that was the reason I went back with the 5.0, just to hit it with the high pressure, and then we'll re-IVUS this and just to make sure.
And that's the circ. Let me take these guys off. Okay.
And then the left main was, I don't know what the MSA was of the left.
Yeah, left main is massive.
Right, it's like 18, 19.
Yeah. So this is the circ stent, this little malapposition in the aneurysm of the circ. Then coming to the ostium of the circ. So actually the circ ostium is more expanded the way it was kissed, with a minimal stent area of about 10.4. So right now, before he re-kissed it, the circ ostium was more expanded than the LED.
And that's why we went back. And I think based on the Excel recent data, the polygon of confluence, the left main should be at least like 10 millimeter square at least. So I think our left main is like 18 to 20 millimeter. The circumflex is 9 millimeter square, and the LED was a little less. It was like about 6.57. So that's why we went back. And now we'll re-IVUS this and make sure that everything is okay.
All right, so your
I think
circ
this
looks
is
okay.
a
Yep.
situation of also trusting your IVUS, because the LED and the circumflex have some aneurysmal positive remodeling change too that you probably want to temper yourself, because it's making the ostium look probably worse than it is, but you don't necessarily want to chase that.
Not true, but I think we were just going by the osteal MSA area, which was still, I think, not optimal. That's why.
Yeah,
but you're right. I think we're not chasing them.
Yeah, I'm saying good job.
So you guys are just sort of touching up here. The boss man is telling me that you guys have done a great job, and then we're going to let you finish off camera. We're going to get to our break a little early because he wants to start the next session about 10 minutes early. So great job, really difficult case, especially to do as a live case. So thank you so much for sharing it. Really appreciate you and your team.